Welcome and thank you for joining us today for our Lunch and Learn webinar on understanding the National Immunisation Program. I would like to start by acknowledging the traditional custodians and sovereign people of the land across which we work. For me, that is the Darawal land. I recognise their continuing connection to land, water and community and pay respect to elders past, present and emerging. I also extend that respect to any Aboriginal colleagues who may be joining us today. This webinar is being recorded and will be available on our YouTube channel within the next couple of days. This is an interactive session, so please ensure you submit your questions to the speaker in the Q&A box throughout the presentation. To view this box, you just hover over the toolbar at the bottom of your screen as shown. At the end of the session, there will be an evaluation survey that will pop up. We appreciate your feedback, so please complete this to allow us to improve the program. These are just some upcoming events we have, and you can register on our website. And just also a reminder of the practice support that we offer as a PHN. And if you need support in anything general practice, please contact the practice support team. We also have a practice nurse liaison support. So again, just use that same email, practicesupport@cesfin.com.au if you need some practice nurse support as well. My Medicare launched recently, and we're onboarding practices and patients. So if you need support with that, there's more information there, or you can contact our team, practice support at cesfin.com.au. All right, now to get started with today's speaker, I would like to welcome Dr. Vicky Sheppeard. She's the Director of the South Eastern Sydney Local Health District Public Health Unit. Vicky is a public health physician who has been working for New South Wales Health since 1999. Her current role as Director, and she is also a member of the TGA's Advisory Committee on Vaccines. So welcome, Vicky. You're on mute.
Okay.
That's great.
Great. Thank you very much, Kira. And hi, everyone. Great to be here. And we'll get going. As Kira said, it's an interactive presentation. So we've got some scenarios coming up. So just to the basics, what is the National Immunisation Program, the NIP? It's an Australian government program, but it's conducted in partnership with states and territories. So the Commonwealth purchased the vaccines, but distribution, provider support, cold chain compliance is undertaken by the states and territories. The Commonwealth do coverage reporting from the Australian Immunisation Register. Now, it's good to remember that the NIP is now a whole of life schedule. Back 8 or 10 years ago, it was really something we just really focused on children, but it's now covering the population through the whole life of the vaccines they need. And the schedule varies with age, Aboriginality, with your state and territory, underlying health conditions, and with pregnancy. So first up, how does a vaccine get onto the National Immunisation Program? So there's a few stages in the process. The first thing is that the vaccine has to be registered in Australia. So that all starts with what's called the sponsor. So that might be the manufacturer or the Australian representative of the manufacturer, usually one of the big pharmaceutical companies, make an application to the TGA. And the TGA do an assessment to see if the vaccine is safe and effective. And if the TGA is satisfied about that, it's added to the Australian Register of Therapeutic Goods. So that then means that the vaccine can be imported into Australia. But that doesn't put the vaccine on the National Immunisation Program. Once it's on the ARTG, it could be purchased privately if the manufacturer imports it or manufactures it here. But to get onto the NIP, there's either a sequential or parallel process where the Pharmaceutical Benefits Advisory Committee, which is the same body that assesses medicines for the PBS, they assess the vaccine for its cost effectiveness. So the safety and effectiveness has been assessed by the TGA, but the PBAC are looking at cost effectiveness, and they draw on advice from ATAGI, Australian Technical Advisory Group on Immunisation, that also gives some insight as to whether the vaccine is going to be effective at a population scale, so whether it's suitable for the National Immunisation Program. If PBAC do make that recommendation with the ATAGI advice that it's cost effective, they make that recommendation to the Department of Health, at which stage they start negotiating a price with the manufacturer and provide that to the minister, how much this vaccine is going to cost, what are the benefits, and then the minister makes a decision whether or not to add the vaccine to the National Immunisation Program. At the same time, ATAGI has a parallel process where they're developing up their recommendations for using the vaccine, and even vaccines that aren't added to the NIP will have ATAGI's recommendations in the handbook to guide private use of the vaccines. So that's the process in a nutshell, and sometimes it can happen very, very quickly, as recently it has, obviously with the COVID vaccines. Also the RSV vaccine got onto the register quite quickly, although it's still not on the National Immunisation Program. Now, as I said, the schedule, the NIP schedule will vary according to which state you're working in. And that's because there's in Queensland, WA and Northern Territory, there's additional vaccines for Aboriginal people. So to keep it simple and to focus on what we need to do in New South Wales, I'd recommend you use the New South Wales schedule, which is the national schedule, but only as it applies to people living in New South Wales. So just keeps it a bit less complicated to look at. And I've got the URL up there, and you might want to have a copy of this handy for quizzes a bit later. So just fairly quickly, the primary course of the schedule, so the one that's been in place for many, many years, the primary course of vaccination for infants, starts at birth through to 6 months of age, and really we're trying to, as quickly as is appropriate for the developing child's immune system, have them develop immunity to 8 key infections. So hepatitis B, diphtheria, tetanus, whooping cough, polio, Haemophilus influenzae B, pneumococcal and rotavirus. And then Aboriginal children at 6 weeks and 4 months of age are also eligible for the meningococcal B vaccine, Bexsero. So the first 6 week and 4 months, pretty busy, quite a lot of antigens to give. And at 6 months, we finished the primary course of those 6 antigens in the hexavalent vaccine. And Aboriginal children with underlying risk conditions might get a 3rd dose of Bexsero at that stage, and all children with risk conditions might be recommended to get a 3rd dose of Prevnar at 6 months of age. So there's a little break until 12 months of age, and a very busy visit on the first birthday. So really important vaccines, meningococcal, ACWY, the finishing the course of pneumococcal, the first dose of MMR, and Aboriginal children finish their course of Bexsero at 12 months. Then 18 months, the first booster for diphtheria, tetanus, pertussis, completing the MMR course and a dose of varicella, and it's not really the first booster, it's really completing the course of Haemophilus influenzae B. Oh yeah, it is the first booster. And then nice long break until 4 years of age, and when we have the second booster of diphtheria, tetanus, pertussis, and the first booster for polio. So then the NIP resumes once children are in high school. So this is mainly delivered through the school program, but of course children may come into general practice or pharmacy for these vaccines. So we give another booster for diphtheria, tetanus and pertussis in year 7 and HPV vaccine in year 7. And now since last year, HPV has been 1 dose for a complete course. And then in year 10, we offer meningococcal ACWI. And so this is a vaccine to get children, young adults, ready for the next high risk period for meningococcal disease as they enter young adulthood. Then apart from people with risk conditions, not much then happens until they turn 50 for Aboriginal people or 65 for non-Aboriginal people. So at 50 years of age, Aboriginal people are eligible for a pneumococcal vaccine and Shingrix. So the pneumococcal vaccines given first as Prevnar 13 and then followed by 2 doses of Pneumovax 23 for Aboriginal people. And of course, Shingrix has just joined the program, which is 2 doses 2 months apart. For people who aren't Aboriginal, the zoster is offered at 65 years of age, and pneumococcal kicks in at 70 years of age with no additional doses apart from just the dose of Prevnar 13, unless they have risk conditions, in which case they are funded to receive Pneumovax as well. And the other main group of people on the NIP with a separate schedule are people who are pregnant, who are eligible for and strongly recommended to have influenza and pertussis containing vaccine in each pregnancy. So just having a quick look at what vaccines are on the NIP this year for influenza. So children 6 months to less than 5 years of age are all eligible under the NIP for influenza vaccine and strongly recommended to have it. And the options are Sierra Grip Tetra and Fluorix Tetra. For people 5 years to 64 years of age, if they have a medical risk condition such as asthma that's moderate or severe, heart disease, liver disease, diabetes, etc., they are eligible for free influenza vaccines under the NIP. And there's a third option there, as well as the Vaxigroup and the Fluorix. This year there's also Flucelvax Quad. And then everyone 65 years of age and over is eligible for Fluad Quad. And I probably should have said very explicitly that all Aboriginal people 6 months and over are eligible for free influenza vaccine every year, and according to the age which vaccine you would administer. So there are some additional eligibility. I'm just going to close my window. Sorry about that. There's some other eligibility for Commonwealth funded vaccines considered to be under the National Immunisation Program. So children that are 5 to 9 years of age who've missed their primary courses of vaccines can catch up all those vaccines listed there. And those who've already turned 10 and missed out on earlier vaccines funded for polio, measles, mumps, rubella, varicella, Hep B, diphtheria, tetanus and pertussis. So they're not offered, for example, the Haemophilus influenzae, meningococcal ACWI at that stage because it's not a risk period for them. But once they turn 15 years of age, they again become eligible for meningococcal ACWY vaccine until their 20th birthday. And then recently, HPV eligibility has been extended to anyone up to 26 years of age who hasn't received a dose before. And on top of that, refugees and humanitarian entrants 20 years and over are also eligible for a number of vaccines, particularly measles, mumps, rubella, Hep B, DTP, and polio. So that's all Commonwealth funded catch-up vaccines eligible under the NIP. And then additionally to that, in the New South Wales government makes some vaccines available for risk groups. So in particular, hepatitis B vaccine for Aboriginal people of any age, and for other people who are at high risk of hepatitis B who've not been vaccinated in the past. And also measles, mumps, rubella vaccine is available through New South Wales funding to anyone born during or after 1966 who doesn't have 2 documented doses of measles containing vaccine. And of course, for women who've just delivered who were rubella seronegative in the pregnancy are also eligible for a free dose of MMR, even if they have been vaccinated before. So this is separate to Commonwealth funding, but those vaccines are listed on the New South Wales Health webpage. All right, I want you to do some work now. So we've got a scenario. So Maria is a 35-year-old woman and comes in asking for influenza vaccine. Maria tells you that she's a healthcare worker, so expects to get the vaccine for free. So what should you do? Should you provide a NIP stock vaccine and bulk bill the encounter, or claim it through the NIP VIP, which is the new pharmacist NIP vaccination program? You could B, provide a private influenza vaccine and charge a visit fee, or C, recommend she be vaccinated at work. Okay, so I can see quite a number of people are entering into the fray here. The majority are saying recommend she be vaccinated at work. It looks like that's so. Let me just. So many things happening. Okay, so that was the correct answer, to recommend she be vaccinated at work, because at the moment you don't know that she's eligible for an NIP vaccine. So you advise her that she should seek her influenza vaccine from her employer, because you'd have to charge her, but she's reluctant. She says she missed the workplace clinics last week when she was having morning sickness. Oh, Marie's pregnant. She has no history of anaphylaxis and has not had any problem with influenza vaccine in the past. So with this new information, should you provide NIP stock and bulk bill, or charge NIP VIP for the encounter, provide a private flu vaccine and charge an administration fee, or C, recommend she be vaccinated at work? Okay, well, we've got 18 responses in. Here, is that results showing, or I need to?
Yeah, I'll stop the poll at about, say, 60% of people responding, and then I'll share. Okay,
great, thank you. Looks like we've got everyone's committed who's going to. So 94% of people have provided the correct answer. So because Maria is pregnant, she's eligible for an NIP vaccine, and that encounter can be charged to the NIP VIP or bulk billed in general practice if you choose. So that's the preferred response there. Okay, so you vaccinate Marie and she's really grateful. Then she wonders how she can prove to her manager that she's been vaccinated. So what do you tell her? If the manager wants a record, they can call your practice. That you upload all vaccination records to the Australian Immunisation Register. She can download a copy via the Medicare app. In your experience, New South Wales Health relies on employee verbal confirmation, so she can just tell her employer that she's been vaccinated. Well, I can see I've made the questions far too easy for this audience. We've got 100% correct there. So the answer is that you tell her that you upload all your vaccination records to the Australian Immunisation Register, and she can download a copy via the Medicare app and use that as proof of vaccination to her employer. And I can tell you for sure New South Wales Health does not accept any verbal record of vaccination for compliance. Well done. Okay, maybe this one is a little more tricky, we'll see. So Ben's 19 years old, comes in to your practice and he's traveling to the United States quite shortly, and he's heard about the meningococcal Y outbreak there. And he tells you he missed his school vaccines, and he says he didn't attend regularly in year 10. So this poll, what do you do? So can you use NIP stock and vaccinate him and then charge a service fee because he's left school? Should you check his immunisation history in AIR? Or use your NIP stock and vaccinate him and either bulk bill or claim from NIP VIP? Okay, that's looking great. A variety of answers there, and I think agree that the most correct answer is that before any vaccination, you really should check in the Australian Immunisation Register because, you know, he was eligible for a vaccine when he was 15 years of age. So make sure that it hasn't been given, and if it has, then he doesn't need a vaccine now. So then let's move on to the next question. So the correct answer is check his immunisation history in AIR. So you check AIR and see he's got no recorded MenACY vaccine. Is he eligible for funding for meningococcal ACWY vaccine? Funded ACWY vaccine? Okay. All right. So once again, the majority have that correct in that, yes, he is eligible. So he's under 20 years of age. So under the Commonwealth catch-up, up to the 20th birthday, that's one of the vaccines that a 19-year-old person is eligible for if they haven't already had it. When you're in the register, you note that he's just had one dose of MMR recorded, and he hasn't had any doses of vaccine recorded since he was 2 years old. So what should you do? Give him the meningococcal ACWY and tell him to come back when he returns from the US for the rest of the catch-up. B, tell him there's several important gaps in his immunity and to be careful when overseas. Or C, tell him there are several important gaps in his immunity and you can catch him up today. So 3 options there. just men ACWY and come back. Just be careful or try to catch up today. Okay, excellent. We have 100% people correct that we shouldn't let Ben go off traveling with important gaps like measles, mumps, rubella in his vaccination history. So, what are the priority vaccines for Ben today? So, oops, that's the wrong question. Oh, okay. There we are. So, this is a long poll. Can you see it all? There we go. Okay. So, choose up to 4. So COVID, DTP, HPV, influenza, meningococcal, ACWY, MMR, pneumococcal, or Shingrix. And then a second question, depending on which vaccines you're choosing there, can you give them all today? And I guess that might vary depending on which vaccines you choose. All right, we've had 12 people, 13, 14. We've had 16 respondents. All right. Okay. So the most popular choices of vaccines for Ben, remember he's 19 years old, about to head off overseas. So DTP is a really good one. Important to be up to date with that when you travel in case you get a tetanus-prone wound. It's the most important reason to have it before travel, but diphtheria and pertussis also useful. The second most important vote there was for meningococcal ACWY, and that's what he's come in to ask for. And as a young person, goodness knows what his activities will be, but if he's going to festivals or otherwise meeting with young people overseas, it's really good to have a meningococcal ACWY in a young person traveling who hasn't had it before. Then the next most popular, thank you very much, is that measles, mumps, rubella. So he's only had 1 dose in the past. So really crucial that he is fully vaccinated before he travels, because we're seeing a lot of measles being introduced at the moment because there's outbreaks in many countries in the world, including in the US. So a number of you have recommended influenza, which I think is a good idea. It probably wouldn't be my highest priority for Ben when he's traveling, but it's always good to consider influenza as a travel vaccine. And depending on the season he's going into, it would be probably more important if he was going into the winter in the Northern Hemisphere. But being a young person, he's not likely to be severely affected by influenza. Then COVID-19 was also selected, and I guess I would check and see if he'd had the infection. At the moment, a primary course of COVID-19 is not really recommended for young people, only on a risk basis. So if he'd had the infection, I probably would skip COVID-19. Pneumococcal, 5 people chose that. At his age, he's not in a risk group, and he's not also eligible for a free pneumococcal vaccine at his age. And 4 people chose HPV. That was one I would have picked for him because he'd missed it when he was young. He's a young man, potentially sexually active, and 1 dose of HPV will give him long-term protection against genital warts, potential genital cancers, and he's still eligible for HPV vaccine at his age. And yes, really any of those vaccines that you've chosen today are great, can all be given at the one time, and there's no problems with giving them in up to 4 different sites. Great, that was well done.
Sorry, Vicky, there's just one more question in that poll as well. Is there any cost to Ben?
Oh, thank you. I haven't scrolled down. Okay, is there any cost to Ben? 6 out of 7 people said no, and 1 said yes. So it probably does partly depend. The vaccines themselves are all under the National Immunisation Program, so there's no cost for the vaccines. In a pharmacy, they could be given under NIPVIP. In a general practice, it's really your policy, I guess, about whether you choose to bulk bill or wish to charge a visit fee for the vaccines. Okay. All right, great. So a few days later, Ben's older brother, Jerry, walks in. Jerry's 21 years old and also traveling to the US in a couple of weeks with Ben. And he heard about Ben's great experience in your practice, and he's also keen to catch up on his vaccinations. Jerry comes clean and explains that when he was a preschooler, his parents joined a cult and refused further vaccination of the boys. So you check in the air and see that Jerry hasn't had any vaccines since he was 3.5 years old. So he has the same vaccine history as Ben. So missing a lot of vaccines. So Jerry, being 21 years old, we have a slightly different situation. So we haven't got a poll for this one, but just have a think about it. So picking the vaccines that I thought were the 4 most important for Ben, meningococcal ACWY, MMR, DTPA and HPV, are they recommended for Jerry? So yes, they're all recommended for Jerry because he's in a high-risk period of his life. He's about to travel and he hasn't had those vaccines either before or they're well overdue. But Jerry, being 21, is he eligible for those vaccines? So this is eligible under the National Immunisation Program or under any New South Wales health program. So just have a think about that. So he's not eligible for a funded meningococcal ACWY because he's already had his 20th birthday. He is eligible for measles, mumps, rubella under New South Wales state funding. Anyone born during or after 1966 is eligible for a free vaccine if they don't have 2 documented doses. He's not eligible for funded DTPA under either program, but he is still eligible for HPV because that catch-up's up to 26 years of age. So he can have HPV vaccine under the NIP. That's the vaccine cost. But then the GP or pharmacy service fee for that service, how is that managed? So basically, when there's no NIP funding or if it's state funded, it's a private arrangement. And of course, you can choose to bulk bill that if you wish. But the HPV, there's no Commonwealth bulk billing available as there is for under 16s, but you could choose to bulk bill it. But in a pharmacy, that would fall under the NIP VIP for the service fee. Okay, last scenario. We'll have a rest after this. Okay, so Marg comes in for her annual flu shot. You know, Marg is a proud Bidjigal woman and very active in the local community. You go and check the Australian Immunisation Register and you see that Marg has a tremendous record of getting her flu shot every year and hasn't had a vaccine yet this year, so you're able to give it. But you also notice that Marg just turned 50 last week, so you ask about if she had a good celebration. So what vaccines is Marg eligible for today? Okay, you're all very fast off the mark there in the poll. So a lot of popularity for influenza. Great. Just give you another few seconds to think about it. We've got 12 respondents so far, so got more people on than that. So okay, well, we've had 15 people committed. Well done. 17. Oh, great. Still coming in. Okay, so 17 out of 18 people would think Marg is eligible for influenza, which she certainly is because she's an Aboriginal person and she hasn't had her flu vaccine yet this year. The next most popular choice is pneumococcal, and that's right, we talked about that at the beginning. So Aboriginal people who turned 50 years of age are eligible for Provenal 13, followed then 2 months later by Pneumovax. So 10 people correctly picked pneumococcal vaccine, and then 8 people correctly picked Shingrix. So once again, Marg being a 50-year-old Aboriginal person is eligible to start her Shingrix course. Some of the other things people chose, COVID-19, I think it's a good consideration and could be discussed. So the current recommendation for people under 65 years old is they can consider a COVID vaccine annually. So we'd have to check when Marg's last COVID vaccine was and really have a discussion about her risks, any underlying conditions, and whether the cost benefit of a COVID vaccine worked for her. We have, 2 people chose DTP, which is, a good point. So that is recommended to have a booster around 50 years of age. That's not funded, but certainly worthwhile discussing with Marg and either today or scheduling a DTP in, but she would have to pay for that. Meningococcal ACWI, a few people have chosen that. I wouldn't have normally thought so. The high risk period for meningococcal disease is in infancy and young adulthood. So we wouldn't normally be vaccinating adults with meningococcal ACWI unless there was an outbreak or they had a particular risk factor such as splenectomy or other types of immunocompromise. MMR, good to think about, and we'd have to check Marg's vaccination history as a child to see whether or not she'd had 2 doses or had been infected. So great, and correctly, no one chose HPV. She's well beyond the age where that would be of a benefit. And should you give them all today? And 10 people, 71% said yes, you can certainly give all those vaccines today. Great, well done. Now, Marg has a couple of kids in tow today. She tells you she's the temporary carer for her grandchild, Molly, who's aged 8. So you asked if Molly's had her flu shot this year. Marg's not sure, so you check in the Australian Immunisation Register and you note that Molly identifies as Aboriginal, but you can't see that she's ever had an influenza vaccine in the past. So what do you recommend for Molly? So some options here. Molly's eligible and recommended for influenza vaccine. You can vaccinate her today. B, you opine that influenza isn't too much of a problem for school-age children, and perhaps Marg can think about vaccination. C, you say that Molly's eligible and recommended for influenza vaccine, but as she hasn't been vaccinated before, she's going to need 2 doses 28 days apart. And D, you do have influenza vaccine for children, but Marg would have to pay as Molly's over 5. So you're all working very hard there. Got 15 responses. Another 30 seconds for people who are thinking. It's a little bit tricky. All right. Looks like we've had 16 people commit there. So that was a little bit tricky. The fully correct answer is C. So Molly's eligible and recommended for influenza vaccine. She's an Aboriginal child. So all Aboriginal people 6 months and over are eligible and recommended for annual influenza vaccine. And if someone's under 9, the first time they receive influenza vaccine, they're recommended to have 2 doses, 28 days apart, and that's fully funded for Aboriginal people. I think response A is also correct. So yes, you should be opportunistically to vaccinate Molly today, but just remembering to remind Marg to bring her back in a month to complete the course. So well done. No incorrect answers there. Very good. All right, so just to recap then, so patients may be eligible for NIP or state-funded vaccines, funded NIP catch-ups available up to the 20th birthday and the 26th birthday for HPV vaccine. Aboriginal people have broader age eligibility and additional antigens available. Always check the air to avoid duplication. And also it helps opportunistically identify any missing doses. Administration fees can be bulk billed up to 16 years of age in general practice and for any NIP vaccines given in pharmacies. All right, just a couple of other things we wanted to cover today. Just a reminder on the cold chain and cold chain basics. So we're dividing this up into equipment, processes, and sorry. So let's just the key equipment that we recommend is a vaccine-specific fridge. Well, not only recommended, it's required. We do recommend having a solid door fridge, but glass doors acceptable. There should be an annual fridge service. There should be a data logger in every fridge. So something like this, something like a clever logger. And there should also be a battery operated minimum maximum thermometer. So even if the fridge has a lovely inbuilt display, it's really important to also have both the data logger and the min max that's separate, because the fridge monitor can malfunction and we need an alternate independent source of evidence of the cold chain to judge what's happened to the vaccines. And the final piece of equipment is alternative storage arrangements. That's probably an esky with a cooler and ice packs ready, bubble wrap, and spare min-max thermometer and data logger. But if you've got a neighbouring practice where you can immediately run the vaccines, that's also an acceptable alternative storage arrangement for when the fridge breaks down. The procedures are also very important. So at least 2 staff members need to have done the New South Wales HEDI cold chain course, which is online, and have their training certificates available. There should be an annual self-audit, and there's an audit available in Strive for 5. The guidelines, the Strive for 5 guidelines, the National Cold Chain Best Practice Management Guidelines. Your procedures should document what you'll do in case of a fridge failure or cold chain breach, and including reporting that to the public health unit. And really importantly, we've had some mishaps with this recently. Practices have actually disposed of the vaccines before we've assessed them, and often they could have been saved. So we need to assess the temperature and all the circumstances before any vaccines are discarded. The other two basics are the monitoring. So you need to record twice a day the reading from the min-max thermometer. So that's recording the actual reading at the time, and also what it's been, the minimum and the maximum during that period, and put it onto a chart that looks like this, and then reset the min-max. The data logger should be recording at least every 5 minutes, and then downloaded or viewed weekly, and having a record of that, so that if in the event there is any cold chain breach, we can know when that started. And then the emergency storage option, which we've also talked about in the equipment section. So if you need any further assistance with the cold chain basics, make sure you've completed that online module, because really everything's covered there. But please, Kira and Mimi and the team are always welcome your calls for any support that you need with managing the cold chain. And now just a couple of slides on, ordering NIP and New South Wales funded vaccines. So in order to order, you need to have what we call a VAN, vaccine account number, and you apply for that online through the State Vaccine Centre. When placing an order, you need to record your existing stocks, how many you have left over of them, and what the expiry date is. Then log into the Vaccine Centre using your vaccine account number and password, and review your ordering history, and then select the vaccines you're likely to need in the next month from both NIP and state supplies. You can make orders twice a month if necessary, and influenza orders can be made as often as required. And then once you've ordered the right amount, not over ordering, declare that you're complying with the vaccine storage and eligibility requirements. So that includes stating that you'll be giving state and Commonwealth funded vaccines in accordance with the eligibility that we've discussed today, and also that you are doing all the elements of the cold chain as specified in Strive for 5. And then once the vaccines are delivered, check the cold chain monitors. So there's a heat sensitive and a freeze sensitive monitor in all deliveries. If either of them is activated, call the Vaccine Centre immediately. But while you're waiting for advice on what to do, store the vaccines in the refrigerator between 2 and 8. Keep them separate from others, and put a big do not use sign on, and record the breach on the back of your min-max chart. So it's important that, because they may still be able to be saved once the State Vaccine Centre's investigated them. So please do put them in the fridge. And then make sure that all your vaccines are stored straight away, and about education of receptionists and other people in the practice, so that everyone knows how to manage an order when it comes in. And finally, I'd just like to recommend a really great resource that we have, New South Wales Health. It's called Cold Chain Toolkit for Immunisation Providers, but it's actually much, much broader than that. It covers all the things that we've talked about today, about eligibility for the different vaccines, and about covers your ordering, really all aspects of vaccine management. It's not just cold chain. So I recommend you have a look at that if you haven't already.
Excellent. Thank you so much, Vicky. That was really informative. And I now would welcome questions if anyone has any. So the first question that's come up, why is the second Varilix vaccination recommended but not funded?
Yeah, great question. Thank you. That's about the cost effectiveness process that happens in PBAC. So while there is an increased effectiveness for the individual in receiving the second dose, so that your lifetime immunity, the chance of that increases significantly after the second dose. At a population basis, it wasn't considered sufficiently cost effective for what it would cost the Australian government. The benefits in terms of disease burden and any reduction in risk didn't meet that cost effectiveness criteria. So that's why it's recommended but not funded.
Yeah, thanks. And I guess that's similar to the meningococcal B vaccinations in children, that they're funded for the Aboriginal babies, but they're recommended but not funded for everyone else.
Yeah, and Aboriginal children have a high incidence of meningococcal disease, so it's cost effective to vaccinate them, but not as cost effective. But that doesn't mean that parents wouldn't make an individual decision to protect their child for personal health benefit.
Great. Well, there's no more questions. I think you've had a very comprehensive education there, Vicky. So thank you very much. Hope everyone has a lovely day, and we'll see you again soon.